alaikum. This is Dr. Tazeen, one of the mentors at StudyMedic, and we are here with OMR series, which is specially designed for your OSCE preparation. So this is the third session of antenatal care, and we shall be discussing a structured discussion about placenta previa and placenta accreta, and along with me as examiner is Dr. Soumya. So all of you know Dr. Soumya, and she will be taking care as examiner, and at the end she will tell us that what further we can improve to get highest marks in this station. Okay, thank you so much, Dr. Soumya.
Thank you, Tazeen. Yeah, thank you so much. Yes. You can start once you are ready, okay?
Hello, I'm Dr. Tazeen, one of the exam going candidates. I have read the instructions and I'm ready for structured discussion.
Okay, so can you please tell me what further information you would want to gather from this woman?
Okay, as this is case of Mrs. Johnny, who is in her third pregnancy with history of previous 2 lower segment cesarean sections. So in this patient, basically, as we start from the beginning, obstetrical history of the patient is important. That what was the previous reasons of her cesarean sections, what was the type of the scar, as well as her whether it was a lower segment cesarean section or classical cesarean section, any intraoperative or any post-operative complication. Along with that, it is important to see the current pregnancy as well, that what actually how the pregnancy has been up till now. Is there any history of any bleeding or any problem for which she has been admitted, or she is taking care with the doctor. Any previous surgery in this patient is particularly important, any surgery on the abdomen, and any medical history of concern for which she is following up with the GP. Along with that, allergies, any medicine, drugs or food allergies, as well as any concerns for the blood transfusion are important in this patient, particularly as we are expecting that she is having placenta previa, which can have further complications as well. So we need to know that whether she is having any concerns for blood transfusion, or what is her blood group, and what is RH type, and what actually is her occupation, and how far she lives away from the hospital, so that if there is any emergency, how much time it will take for her to reach the hospital.
Okay. Yeah, this, as you rightly said, the previous 2 cesarean section was done for breech, and she had just a spotting in the beginning of her first trimester. After that, she has been absolutely fine. So, and she is not Jehovah. She doesn't have any drug allergies. So, how would you go ahead optimizing her antenatal plan of care?
For this patient, basically her optimization of care, it will start from the antenatal period when she is coming to us. We have to keep in mind that as she is a case of placenta previa, so her hemoglobin levels should be optimized, and then it should be discussed with her that we have to go through the regular antenatal care, but we have to consider steroid at 4 to 35 plus 6 weeks of gestation. If there is any complication which is arising, the patient should be counseled that she may need hospital admission, as well as if she stays asymptomatic, there are no bleeding episodes, then we can plan her pregnancy at 36 to 37 weeks of gestation. Otherwise, the delivery time, it can be individualized, number one, depending upon her situation, that whether she is having bleeding episodes, what about the hemorrhage, as well as if she is having repeated bleeding episodes, then we can deliver her earlier as well.
Okay, because it is a 2 previous cesarean section with the placenta, like with the placenta previa. So, if you are suspecting placenta accreta spectrum, actually, what are the things which can be suspicious of placenta accreta spectrum, and how would you go about confirming your diagnosis?
The things which can be suspicious for placenta accreta spectrum, they can be starting from her history, like she is having previous 2 cesarean sections, which is a significant thing in her history, as well as if she had any history of any surgery which was done for on the uterus, any history of dilatation and curettage which is being done for the patients. Advanced maternal age is also a risk factor for the patient, or if she has used any assisted reproductive techniques, that can also lead to placenta accreta. And then the diagnosis, it can be made in the antenatal period as well. If we are having placenta previa, then we can go for scan which can find out the adherence of placenta, as well as we can go for gray scale scan which can have specific features which are more specific for the diagnosis of placenta accreta, like moth-eaten appearance can be there, placental lacunae can be there, and the scan findings, they can be enhanced, or we can use MRI to confirm our ultrasound findings for in these kind of patients.
Okay, so if you are suspecting, if you have diagnosed a placenta accreta spectrum in this particular patient, how would you go about managing her?
The management in these patients, basically this should be a multidisciplinary team, and we have to involve the consultant obstetrician, consultant anesthetist, as well as the neonatologist should also be informed. Blood bank should be informed about the blood arrangements as we may need in these patients. And if the interventional radiologist is also available, we can look into that opportunity as well. And when we are actually the delivery of these patients, it should be in the specialist unit where all these facilities are available, and we can look at other options of delivery, what are the fertility concerns of the patient, and the management, it basically depends upon the fertility concerns of the patient, that whether we have to go for uterine conservation, or we can have early recourse to hysterectomy as well. So the options can be that we can, if the fertility concerns are not there, as the patient, she is already having 2 healthy babies, so we can straightforward go for cesarean hysterectomy to prevent the hemorrhage as well as the implications of further blood transfusions and further complications. Otherwise, it can be that if we have to go for uterine conservation surgeries, then we can leave the placenta in situ, we can close the uterus, and then we can plan further management. Other option can be that we can incise the parts of the placenta or the uterus, and then we can close the uterus, which can also be a option for these patients. It all depends upon the fertility wishes of the patient and how the situation is.
Okay, what are the components of placenta accreta care bundle?
Placenta accreta care bundle, it actually comprises of again a multidisciplinary team where the consultant obstetrician should be taking care of the patient throughout the antenatal period as well as for the delivery. Consultant anesthetist should be there to take care of the anesthesia and all the related complications of the patient. Blood and blood products should be available for the patients, as there are higher chances that these patients, they can need the blood products. Multidisciplinary involvement should be there. Interventional radiologist, it should be informed if they are available in the hospital, and discussion, consent, and all the complications of hysterectomy, they should be discussed with the patient, so that if we are having any such complication, there is early recourse to hysterectomy.
Okay, so any particular post-op management you would think of? For example, if this woman goes for cesarean hysterectomy, so any particular post-op management you would want to highlight?
If the patient, she is going for post cesarean hysterectomy, in the postnatal period, definitely we have to have a look for, we have to take care of this patient for the postpartum hemorrhage, as well as we have to take care of the venous thromboprophylaxis in these patients, and we have to do the risk assessment, and we have to go for thromboprophylaxis as well.
Okay, perfect. Thank you. Yes, so yes, you can put your reflection across, then I would be telling you a few things. It was very well done station, but couple of things which we can make it a little more retuned. So you can go ahead with the reflection. How did it go?
Actually, it was okay, but the thing is that the description of the series of the things and all these things that can be, more improved, and so that it is very crisp and clear for the examiner.
Yeah, I think it overall went really well because the history you focus more on, because generally whenever we ask the history for the candidates, they go from just like patient simulated tasks. That's a very important point to focus on a particular case. So you started off with the obstetric history telling exactly and what you want and probably justifying as well, like what you are thinking. Okay, and I like the fact that you summarize the case. But only one thing, do not introduce as Dr. Tazeen because you are talking to your colleague. That's the only thing. And once you summarize, you went very well with the things. Yeah, just specifying, like if you could have told me like the 2 previous CS with placenta previa. So I would always ask the history thinking of placenta accreta spectrum. You were talking about that, but signposting that, my marks would be ticked faster. And I think the optimizing the care was a good one. You spoke about Jehovah's Witness, suspecting the diagnosis you covered, treatment options you covered very well. Only when you came to the post-op, you could just say it's not a big thing, but if you could say clinical and clinical governance part. Clinical part, you covered everything. Venous thromboembolism, anaerobic mobilization, all those things. Clinical governance part of debriefing, documentation, because right now they are asking about all this. So just those things. Otherwise, it's a very well done station. It would be a clear pass station for sure. Yeah.
Thank you so much. Thank you. Thank you.
Yes, if you want to tell like the most important points, what they have to be covering so that it would be easy for them.
I will go through all these things, that these are the questions, or the questions can be modified for the candidates depending upon the case, but you should have a clear idea that how you are taking care of a placenta previa or accreta patient, and then you have to go through antenatal care, then how you will be taking care of what would be the management of this patient labor, how you will plan her delivery, what would be the modes of delivery, and as Dr. Soumya rightly said, that what would be the post-operative care of the patient as well as the clinical governance part of this patient. That is very important. You should have clear idea about when to give the steroid, when to plan the delivery, what can be the complications, what are the multidisciplinary teams they are involved in the care of this patient. That is important in this patient, and then definitely you should be taking care that what complications you can encounter and how all setup should be available for the patient, where she should be delivered, what all the consultants should be available to take care of this patient. That is very important in these cases. That's
yes.
all.
Only one thing, the level 2 care facility in the placenta care bundle. So like you covered the MDT, that's an important buzzword. And for sure, they're going to ask this placenta care. This is a very, probably clinically also we are seeing this often. So obviously this would be asked. So as you rightly said, if you imagine somebody managing placenta accreta, that would be fantastic. So yes, thank you. Thank you, Tazeen, for the wonderful effort. Thank you so much.
Thank you so much. Thank you. Take care.
Thank
Bye
you.
bye.
Bye-bye.